holistic cardiometabolic and liver care。那这个主题，我想这个incretin based therapy 或是我们现在更扩大叫做 NUSH 这个 nutrient 这个 stimulated hormone 的这个领域真的是蓬勃发展了。那一开始是2-3种药，后来变5-6种药，现在可能10几种药，所以未来大概这个领域会有更多跟令人兴奋的这个进展。那所以谈论这个主题，如何把这些我们可以临床上可以用的这些新的武器应用到临床。那除了本来我们就知道在这个肥胖、心血管、肾脏领域之外，那新的 evidence 特别是在肝脏方面 muscle D fatty liver 的这方面我想会是对各位在临床非常有用的一个这个演讲内容那因为这个其实 Professor Kahn 现在已经在线上，那但是考量到这个连线稳定的问题所以是请他以预录的方式呈现这个演讲的内容。那在演讲内容结束之后他也会在线上就是real time 跟大家互动那进行这个 Q&A 那到时候大家有什么问题就可以直接跟这个 Professor Kahn 来这个提问那我们现在就以热烈掌声欢迎这个 Professor Steven Kahn。
So I'm going to talk largely today about advancing the role of semaglutide in holistic cardiometabolic and liver care. And I thought I'd start with this slide, which I think is something we all know, but really need to be reminded of, especially as it's relevant to this talk. And we're talking about the global burden at around about this time. There's no doubt, unless we do something, that this global burden is going to become even worse as we go forward. So this includes obesity in nearly 900 million people, type 2 diabetes, which is a major focus of this meeting, in 500 million people, cardiovascular disease in over 600 million, chronic kidney disease as defined by the KDIGO criteria in 850 million. And I think the new thing that's emerging, which we've got to worry about as endocrinologists and as primary care physicians, is metabolic liver disease, shown here as MASH, estimated at 411 million. And here's now the outline of the talk that will try to address most of these different things that I showed you on the previous slide. And the first part is about obesity management and looking at the quality of weight loss with semaglutide as we advance holistic care. Now, I think you all know data such as this, which shows that when we reduce body weight, we can improve obesity-related complications and diseases. And it is thought perhaps that with greater amounts of body weight, basically from lifestyle interventions, we will get better effects to do things like preventing diabetes, reducing hypertension, improving dyslipidemia, reducing liver fat, and then also inflammation, sleep apnea, osteoarthritis, diabetes remission, preventing cardiovascular disease. It goes on and on and on. But the important thing to recognize is that when we come to talk about the GLP-1 receptor agonists, in particular semaglutide, which I will discuss with you in a while, what we recognize is it's not just weight loss that does this, as I'll point this out to you. Other things are also important in the process. And the other thing that's really important is if we're going to be able to support the health benefits of reduced body weight, just as we know with lifestyle, as weight increases again, the benefits disappear. The same thing holds here. If weight increases, then we lose some of the beneficial effects. So let's start then looking here at semaglutide, a dose of 2.4 milligrams in individuals with obesity. And on the left there, you see the step 1 study, one of the very first studies done with semaglutide, basically testing the hypothesis that you could reduce body weight with this GLP-1 receptor agonist. And you can see that individuals started with a mean body weight of 105 kilos, and those in the semaglutide arm lost somewhere around about 16 to 18 kilos compared to placebo. And what you will also appreciate, which goes back to what I was saying about maintaining weight, is that when you stop the semaglutide and look at the extension, you can see that the weight starts to increase. So that within a year of stopping semaglutide, about 2/3 of the weight reduction has disappeared. So this tells us, I think, that we need to keep people on these medications, which is, I think, something we are learning more and more and more. If you start on one of these drugs, it's likely that it's a medication you're going to have to use for life. And that's shown here again in the step 5, which is a longer duration study, showing again now that at the end of approximately a year, you get weight loss, near maximal weight loss, but you have to stay on the medication to fundamentally keep the weight off. Now, what else have we learned from these studies, and particularly step 1? And these are data that were presented by Carl LaRue, who lives in the UK. And what he did was to take the individuals in the study and ask what happens to those individuals with or without the metabolic syndrome at baseline who were randomized to placebo, as shown here. And you can see that 46.7% of them did not have the metabolic syndrome, and more than half of them had the metabolic syndrome as defined by the classical criteria. Over the period of that treatment, which was for just over a year, you can see that there was very little change in the number of individuals who had the metabolic syndrome or did not. Probably the shift is in part towards not having the metabolic syndrome because of the placebo effect of being in a intervention study. Now let's contrast this now with those individuals who received semaglutide. You can see at baseline, if you compare the two pie charts above each other, that the distribution was very similar. However, with semaglutide, the outcome was quite different in that you can appreciate here that by the time one was done treating people for a period of 68 weeks with semaglutide up to a maximum dose of 2.4 milligrams, now about 3/4 of them no longer had the metabolic syndrome, which would represent changes in anything from glucose, certain lipids, waist circumference, body weight. We all know what the different factors are that are included in this, so clearly there's a benefit. But the other thing I think that we've learned from step 1, and which we've learned from a number of the studies that I'm going to be talking about without actually showing you these data every time, is that if you take people who have pre-diabetes at baseline, right, and treat them with semaglutide versus placebo, you get very different outcomes. So you can see here that in step 1, when they randomized individuals, those randomized to semaglutide, about 45% had pre-diabetes, and those randomized to placebo, about 40% had diabetes, and the rest of them at baseline, because this was an obesity study, were normoglycemic. After 68 weeks, you can see the differences in outcomes, right? What you see is that with semaglutide, you now can appreciate that somewhere close to 85% of these people now have normoglycemia, whereas with placebo, it has not changed much from the 40% to the 49%, as you see in yellow on the right, and some of the individuals have actually gone on to develop diabetes. So clearly what we can appreciate from these studies in people with obesity and no diabetes in step 1 is that these individuals get a beneficial effect with semaglutide over a year to change their dysglycemia from impaired glucose metabolism to normoglycemia. Now, what about semaglutide 7.2 milligrams, which is a higher dose of the medication, which is now being studied in this program called Step Up? And what you see here are two different studies. One on the left in blue, the Step Up program, which is individuals with obesity but out diabetes as defined by hemoglobin A1C less than 6.5. And on the right, the Step Up in type 2 diabetes, where you now have a diagnosis of diabetes based on hemoglobin A1C of between 7 and 10. You can see the baseline characteristics here. In the one study, there were more men. The age was a little bit higher in those with type 2 diabetes. The BMIs were both similar. These people are very obese, and their waist circumference means that they're very large. Remembering, of course, that most of the patients from these studies do not come from Asia. When you look at the hemoglobin A1C, as by definition, it was elevated in the Step-Up T2D group, and they had had diabetes for an average duration of 8.4 years. So what did we see? So here you see what happens in the Step-Up program in individuals in terms of body weight. You can see that body weight decreased with both 2.4 and then a little bit more with semaglutide 7.2 milligrams in this group. And what we appreciate when you look deeper into the data is that about half of the individuals with obesity who were in Step Up treated with semaglutide had a weight reduction with a 7.2 milligram dose of more than 20%, really meaningful weight reduction. And then if one looked at the individuals in that group again, about a third of them actually lost 25% of their weight, large amounts of weight loss. Okay, so what about in the step-up let me actually go back and point one more thing out. Look at the two semaglutide groups at the bottom, the 17.5 and 20.7 change in body weight as a mean baseline change. When one looks now at the individuals with step-up T2D, these are the people with diabetes, you again see that the higher dose of semaglutide, the 7.2 milligrams, is more successful in reducing body weight than the 2.4 milligram dose does. And here you can see, and this is the important thing, notice that the maximum amount of weight loss is less in the people with diabetes, despite them getting the same amount of medication. And this finding holds up across the board when we look at GLP-1 receptor agonist therapy, that the people with diabetes do not experience as much weight loss as the individuals who do not have diabetes. And this to me is very important to set expectations with your patients. So if they've heard you can get 25% weight loss with a certain drug, and they're thinking about people without diabetes, if they have diabetes, remind them the weight loss is not that great, and therefore the expectations should be modified, therefore. When we look at those individuals in step-up T2D, about 40% of those who had obesity and type 2 diabetes, with the 7.2 milligrams achieved a 51%, achieved greater than 15% weight reduction, and about a quarter of them achieved weight reduction of approximately 20%. Also importantly, when we think about the step-up T2D, recognizing these people have diabetes, you can see that both doses of the medication lowered the hemoglobin A1C by approximately 1.6 to 1.9% hemoglobin A1C units. The thing here again, that is a message I'm sure you all know, is that there's a different dose-response effect of semaglutide on glucose versus weight, so that you need higher doses to get the maximal weight reduction, whereas you can get away with glycemic control with lower weight reduction. As you can see here, there's the same amount of glycemic control despite the fact that you're using a lower dose. And lastly, when one looks at side effects as shown here, the 7.2 milligrams provides a very favorable benefit-risk profile, very similar to everything we've seen with GLP-1s up until now, and certainly no different to semaglutide 2.4, with the bulk of it being GI adverse events. There's one last thing I want to point out to you about the semaglutide 7.2. I know that it is not approved yet here in Taiwan, but yesterday the US Food and Drug Administration approved this higher dose, so that in the US, starting in a few weeks, we're going to be able to choose to give people either 2.4 or 7.2 milligrams to achieve more weight loss in these individuals with obesity. So in summary, when one considers what we've been talking about related to obesity and type 2 diabetes, we see great weight loss, and that I would suggest to you, as shown in the left-hand box, that patients who are treated with semaglutide will lose about 21% of weight loss, and that this weight loss starts very early. But importantly, it does not normally reach maximal till beyond a year. So again, setting expectations with your patients is important. When a patient loses body weight due to semaglutide, the bulk of the weight loss comes from fat, which is exactly what we would want, rather than large amounts of it coming from the muscle. But importantly, I think, and this has been a big contentious issue, the issue of sarcopenia and muscle weakness in people with GLP-1s. My personal view, and it's my personal view, is that this has been overblown some, and that really what we see in most individuals is that they are able to be mobile and function. It's only the rare individuals who really have problems with muscle function. So let's turn now to the second aim, which is to look at cardiovascular disease and type 2 diabetes. And here is some background, again, is some epidemiology, which you're all very well aware of, that here in 2021, 600 million plus people have known cardiovascular disease, and it's expected that the number is likely to nearly double in the next 25 years. And when we look at those individuals who have obesity, about 4 out of 5 of them who have obesity will also have underlying cardiovascular disease, and that about 2/3 of the deaths in obese people are linked to cardiovascular disease. So this is really an important outcome that we need to address, and as you know, there's been lots of progress in this area. When we look specifically at type 2 diabetes and cardiovascular disease, 1 in 3 individuals with type 2 diabetes have known cardiovascular disease, and half the deaths that occur in people with diabetes, type 2 diabetes, are related to cardiovascular disease. Also, as shown here, and which is nothing new to all of you, there's a variety of risk factors, including hypertension, hyperglycemia, inflammation, dyslipidemia, and central adiposity, largely intra-abdominal fat, that all together will increase the multimorbidity related to obesity and type 2 diabetes, leading to the outcomes of myocardial infarct, stroke, and ultimately cardiovascular death that we need to worry about. What we recognize is that the GLP-1s, and in this instance semaglutide, are very capable of turning around many of these risk factors. So as shown here on this slide, semaglutide in a variety of studies has been shown to reduce body weight and to reduce central adiposity by reducing waist circumference, improving glycemia as measured by hemoglobin A1C, lowering blood pressure, decreasing inflammation through measurements of CRP, or as indicated by CRP, and also improving dyslipidemia. Now, what does this all translate into? And I'm going to share with you data now from 4 different studies: SELECT, SUSTAIN-6, SOUL, and FLOW. And let's start here with SELECT, which I'm proud and happy to say I was part of the steering committee or the executive committee for this study. And I can tell you I was at the American Heart Association meetings when these results were announced, and the whole audience went crazy. It was unbelievable, because this was the first ever demonstration that using a GLP-1 could reduce cardiovascular events in people who are obese but do not have diabetes. Up until now, everything had been related to diabetes. And you can see from the study in this paper from Michael Linkoff in the New England Journal that we were able to reduce MACE events by 20% in those patients treated with semaglutide who were obese and did not have diabetes. What is also interesting and important is that you can see that the separation between the two curves actually occurs early, right? And that is incredibly important because body weight has not changed dramatically at that time, which talks very seriously to the fact that these medications have effects that go well beyond just weight reduction. And so this is something I think you can tell your patients too. You might not be somebody who gets 20%. You might be somebody who only gets 5%. But that 5% weight reduction can turn out to be beneficial. And some of that is actually shown here on the next slide, where we had a pre-specified analysis looking at the time to first MACE event by the change in body weight at week 20. So that's very early on. And we categorized people as having lost more than 5% or less than 5% in terms of body weight. And you can see the key up at the top there. On the left are those people who've lost less than 5%, on the right, those who've lost more than 5%. And what you see here is the slopes, the curves for placebo. And what's interesting here to me is that those individuals in the placebo arm who lost more than 5% actually did poorer. And we don't know the answer for this. My view on it, my personal view, is what we're seeing is unintentional weight loss in this group, which we all know typically underlies bad disease, for example, cancer. So it's quite possible that this unintentional weight loss, while there was greater weight loss in the placebo with a poorer outcome, is related to disease not linked to cardiovascular disease. On the other hand, when you look at the group treated with semaglutide, it doesn't matter whether they lost a lot of weight at the first 20 weeks or little weight in the first 20 weeks, the benefit was the same. Again, talking to the fact that the protective effect of semaglutide is not linked purely to body weight reduction. What about now in SUSTAIN-6, which was a study, one of the first studies done in people with type 2 diabetes? This one, as you can see here, over a period up to 40 years, produced a 26% risk reduction for MACE in individuals who had type 2 diabetes and cardiovascular disease or chronic kidney disease. If one looks at SOUL, which is another study which was done in this instance with oral semaglutide with 14 milligrams of the oral medication, the risk reduction of MACE was 14% in these individuals who again had type 2 diabetes and cardiovascular disease or chronic kidney disease. So we can see here from the two studies I've just shared with you, SUSTAIN-6 and SOUL, in very similar populations, that oral and injectable semaglutide are effective, though I would argue, at least based on the hazard ratios, understanding that the populations are not absolutely identical, that the injectable might have been marginally better. And finally, FLOW, which was a study in people with type 2 diabetes and chronic kidney disease, you can see here again an effect of injectable semaglutide. Now up only to a dose of 1 milligram, we're able to see a reduction in MACE events, which is significant based on the confidence intervals in these individuals. So therefore, I would suggest to you, from everything I've shown you with SELECT in people who do not have type 2 diabetes, and from SUSTAIN-6, SOUL, and FLOW in people with type 2 diabetes, both injectable and oral semaglutide are capable of reducing the risk of 3-point MACE, which is acute myocardial infarction, acute stroke, or cardiovascular death. So in summary, when we talk about cardiovascular events, we can say that from SELECT, we get a reduction in MACE risk by 20%, and that early onset weight loss occurs and seems not to be a differentiator of individuals with semaglutide treatment. In SOUL, in people with type 2 diabetes, cardiovascular disease, or kidney disease, again, we see cardiovascular safety and benefit with both injections and oral treatments. And then if we turn to individuals as shown in FLOW who have chronic kidney disease and diabetes, here the study was stopped because of overwhelming efficacy on the kidney and a reduction in cardiovascular disease endpoints. I haven't shown you the renal data, but the renal data fit with what we see with the GLP-1s, and some of the changes we see are likely due to glycemic improvement because many drugs produce improvements in things such as albuminuria with glycemic control. The difference here is that we get a reduction in the rate of loss of GFR, suggesting that there are more benefits. And so let's turn now to the last part of the talk to talk about MASH, which is, I think, the new kid on the block when we're thinking about the CKM framework, which is a new term that's been coined by the American Heart Association. We explore what semaglutide can do as a therapeutic for MASH over the next few minutes. So, again, just like with the other two sections, what does the epidemiology teach us about obesity, type 2 diabetes, and MASH? And if you look across the top of the slide, you can see that the global prevalence of liver disease, fatty liver disease, which we now call MASLD, is about 38%. We're talking about Taiwan, the US, New Zealand, wherever you want to go. And when you look at MASH, which is steatohepatitis with inflammation, cirrhosis, and increased risk of cancer, about 1 in 20 individuals now have that form of liver disease. When we look at those people with MASH, those people in that little circle on the right, you can see that about 2/3 of them will have type 2 diabetes, and about 1/3 of them will have obesity. So what does this speak to? And I'm not going to talk about this at all more than what I'm about to say here, is that it's critical as we learn more about this disease and its impacts, which I will talk to you about on the next slide, that we consider individuals with type 2 diabetes and with obesity as candidates to be screened for liver disease, not with all the sophisticated testing that one can do, but with procedures such as the FIB4, which is something you can do very simply from the office when you see these patients. Now, why do we worry about this disease? What you see here on the left is what happens ultimately to people as the disease progresses. It goes from having fatty liver to MASH with inflammation, and then ultimately to fibrosis and cirrhosis, which I think we all recognize as really poor outcomes from a hepatic standpoint. If you look on the right, what happens in those people with fibrosis and cirrhosis? First of all, you get increased liver-related events and 16 times a higher risk of dying due to liver problems. There's an increase in malignancy, particularly hepatic cancer, and mortality and cardiovascular events are also higher, noted as you can see there with the tombstone and the heart, about a 4 times increased risk of these happening in individuals who have MASLD and MASH. So what should we be doing about it? In my view, we should be targeting the liver and understanding that along with the liver, there's the potential for benefits on some of the cardiometabolic risk factors that go along with liver disease. So this would include, as you see here, body weight, a lipid profile, glycemia, and other cardiovascular parameters, including blood pressure and inflammation. This, we hope, would help potentially in reducing MASH, reducing the steatohepatitis, perhaps if it doesn't reduce it, stopping disease activity, halting fibrosis progression, which is ultimately a bad outcome, and therefore resulting also potentially in improved fibrosis and the prevention of cirrhosis. So what are the data out there to do this? And so some of the data comes from a study called Essence, which was led by Arun Sanjal from the University of the Virginia Commonwealth in the United States. And you can see here 3 components of the results that were shown in a New England Journal of Medicine paper that was published last year. You can see on the left that MASH resolved in about 63% of patients treated actively with semaglutide, 2.4 milligrams versus placebo, where it was about 33%. So there's a natural history we see here that MASH can come and go depending, I guess, at what phase it's at, but you do not see any change in liver fibrosis. So this is a benefit. What if we now ask the other side of the question? What happens to liver fibrosis when MASH doesn't change? And you can see here again that semaglutide, shown in purple, has a beneficial impact to reduce the development of liver fibrosis. And then in the right-hand panel, you can see, in fact, that in some patients we see both of these happening, right? A reduction in steatohepatitis and an improvement in liver fibrosis. I don't believe, at least from my knowledge yet, that we're at a point that we can predict who's likely to get these benefits, but I would argue to you that these benefits are certainly another useful treatment approach, provide another useful treatment approach through the use of semaglutide. What we also observed in these studies, as shown here by the 2 liver enzymes, is that you get improvement in ALT and AST with semaglutide, and then also using elastography, VCTE, you can see here that there's also a reduction in liver stiffness. All of these suggesting that semaglutide is having a beneficial effect on hepatic function and hepatic fibrosis and ultimately inflammation. What was also very important to recognize, and which is the same thing that holds up now with cardiovascular disease, and I will be talking about it some more related to diabetes tomorrow and pre-diabetes. Weight loss is one effect semaglutide has, just like all the other GLP-1 receptor agonists-like drugs, but weight loss does not provide the answer as to everything that happens. There are things that are going on with these medications well beyond weight loss that are important in having their effects. And I believe a lot of this may be related to inflammation in a variety of different organ systems, ranging from the blood vessels to the liver and so on, which I think is very important. When you look here, you can see that the change in body weight in the Essence study was about 10.5% from baseline in those individuals treated with semaglutide, just as we would expect, and a small 2% reduction in the placebo arm. When you look actually at what happened to the different components, whether you're looking at MASH resolution or liver fibrosis in the dark purple, or those other parameters and the ELF score that I showed you on the previous slide, you can see that at the end of the day, that percentage in the middle is using mediation analyses. That's how much of these different measures were improved by weight loss. And barely 50% was achieved in some of these situations, and as low as only a quarter of the explanation for the ALT change can be derived from the reduction in body weight, suggesting, therefore, that we need to really think seriously about weight management as part of it, but don't think about weight management with our patients as the answer to all the different medical issues they may have. There are other effects that are occurring with these medications. Furthermore, if you look now again in this study at cardiometabolic risk factors, blood pressure, glycemia, inflammation, and lipids, all of these improved more in the individuals treated with semaglutide than with placebo. And just as in the case with everything else, the most common adverse effect was what we observed in terms of GI side effects. So in summary, when I think about MASH, I think we can say that the data from this study from Arun Sanyal, published in the New England Journal of Medicine last year, we're seeing histological improvements where you see resolution of MASH and no worsening of liver fibrosis in 63%, an improvement in liver fibrosis, and no worsening of MASH in 37%. There's also clearly benefits, target organ benefits, based on the measures I showed you, ALT, AST, and elastography with the FibroScan. And then also, as I showed you on the last slide, there's improvements in cardiometabolic risk factors as well, which are also only partially mediated by obesity. And that at the end of the day, what we're seeing is improved cardiometabolic risk factors, a reduction in body weight, an improvement in hemoglobin and A1C, and with all that, a whole constellation of things that are changing, which says to me that while we may be approaching the liver primarily in a study such as ESSENCE, we're having positive effects on a variety of other risk factors and potentially changing those outcomes at, for example, glycemia progression to diabetes. So what are then the take-home messages from what we've seen over the last decade or so in studies with semaglutide? First, I think high doses of semaglutide achieve superior weight loss. There is a dose-response effect, and now we're in a situation in the United States where we can be using 7.2 milligrams of semaglutide for weight loss. The weight loss is primarily by reducing body fat and largely by intra-abdominal fat, and muscle strength and function, I believe, are largely preserved, and therefore most of these patients do not have to worry too much about it. If you think about it, if there's a loss of a little bit of muscle mass, it is disproportionately less than what we're seeing with body fat. These patients are having to carry less body weight typically. So I think in most instances, this problem of sarcopenia is, in my mind, a little bit perhaps overemphasized. Semaglutide consistently reduces MACE risk in people with obesity, as in SELECT, or with diabetes, as I showed you in the other trials, SUSTAIN 6, SOUL, and FLOW. And the important thing here again is that the effect is independent of the degree of weight loss. I have said this over and over again. If you take anything out of here today, that's, I think, the one big message you should take with you. When it comes to diabetes and glycemia, semaglutide reduces glycemia. In other words, it lowers glucose and improves glucose tolerance and hemoglobin A1C in people who have established diabetes, but also in people who have prediabetes. And the reduction in glycemia in people who have prediabetes underscores an important role of these medications, because I believe they're very effective, therefore also in slowing the progression of diabetes. In other words, a lot of the patients with prediabetes treated with these medications, we may save them from going on to get diabetes by the fact that these drugs are working on the beta cell to improve insulin secretion. And lastly, when we talk about the liver, I believe that semaglutide at 2.4 milligrams, we know nothing at this stage about 7.2 milligrams, resolves steatohepatitis and improves liver fibrosis. And this has been seen by the histological resolutions that have been demonstrated on biopsies in these studies, and that it improves other measures, non-invasive measures of liver function. It also, as I mentioned, improved cardiometabolic risk factors in these patients, which I think, again, is important. So what happens now? Let's look at everything I've talked about on this last slide with you today. This is now, again, something that is being produced by the American Heart Association, which was published a couple of years ago in a position statement of theirs as to how they think we should be tackling the diseases related ultimately to cardiovascular disease, because cardiologists are actually only interested in the heart, unless the medications like GLP-1 that were developed for diabetes can help the heart. So you can see here they've come up with a variety of stages. Stage 1, which is basically obesity. Stage 2, where you've got metabolic risk factors, as indicated there. You can see glycemia, triglycerides, hypertension, the metabolic syndrome, and then chronic kidney disease. At stage 3, they talk about subclinical cardiovascular disease and this cardiac kidney metabolic syndrome, CKM syndrome. And then lastly, at stage 4, you have clinical cardiovascular disease, which now is resulting in outcomes related to stroke, cardiovascular events, diabetes, etc., chronic kidney disease. What I'd like to suggest to you is, based on the data that we've been gathering now over the last few years, we should consider adding metabolic liver disease to stage 2 as a risk factor. It's a risk factor associated with an increased chance of getting diabetes. It's a risk factor associated with an increased chance of getting cardiovascular disease and dying. So what does this mean to us? And I don't know what different specialties you all represent, but I think it means we've got to start thinking differently about how we treat our patients. So we start off with the primary care physician, whose role is to deal with stage 1, and I would argue to you now to be screening for metabolic liver disease in people who are obese and have type 2 diabetes or are at risk for this. And I think metabolic liver disease now belongs to that metabolic risk factor and CKD group at stage 2. What it means also is that our patients, depending on the ability of our primary care physicians to treat them, and I think over time this will get better, should be seeing as you go from left to right, after they've seen the primary care physician, perhaps an endocrinologist/diabetologist, a cardiologist, a kidney specialist, and a liver specialist, depending on where they are on the stage of disease. Because I think we're actually now at a time that we weren't at 20 years ago when I was treating lots of patients, where we can really offer our patients something that is valuable in reducing cardiovascular disease, renal disease, liver disease, and diabetes, and that is the GLP-1 receptor agonist. And as I've shared with you today, from the data I've shared with you today, semaglutide fits across the whole spectrum of disorders. And I will end there.
Okay. Thank you, Professor Kahn. Here we have about 800 people online, and maybe 30 or so people on site. So let's go into the Q&A question. And some audience will have their question in English, but if they do this in Chinese, I will translate. Okay. So the first question is that, what are your recommendations for patients who have reached their weight loss goal? Would you continue or discontinue treatment? That's the first question.
So that's a really good question, and before I answer it, I want to thank everybody for coming. It's your Sunday and it's the morning and people should be at home enjoying the family. So I appreciate you all coming to listen. So this is a very interesting question, because I think we're all coming to the conclusion now that in most patients, when you stop the medication, they're going to get weight regain. So I'm not sure, unless you can find some other approach where you switch them perhaps to some other weight loss agent that's not a GLP-1 like semaglutide, that you can ever get them off. What we're also seeing and starting to see now are people are starting to study whether you can actually take somebody who was on a maximal dose of the one drug and reduce the frequency to every 2 weeks, or reduce it every week to a lower dose and see if you can get maintenance. But at this stage, I don't think there's enough data to conclusively say. And so I think from my perspective, to the patients, I think if you commit to start to take a GLP-1, you're likely going to need it, some form of it, for the rest of your life. It's sort of saying, well, you've got hypertension, you've got to have an antihypertensive, you've got diabetes, you're going to get something glucose lowering. Obesity is a disease. You've got obesity, we can treat it, but you can't just stop your treatment.
Yeah, thank you. I think the importance that we should think obesity really as a disease. So you have to continue the treatment. And when hearing your talk for the second time, I have a following question that you emphasize that the cardiovascular benefit is independent to their weight loss. And in clinical situation, we will found some people who are non-responders for weight loss effect. So in these non-responders, based on the benefit, potential benefit in cardiovascular disease, do you think we should continue the use of this drug even without with a weight loss less than 5%?
Yeah, I think, Chris, that's a great question. It's another one I think we all struggle with, right? And everything I'm going to say now, let me preface it by saying that none of this is labeled indication. This is stuff we're doing. So when you go back, for example, to SELECT, what we're finding, and there's a paper that's, I think it's more or less been accepted to circulation, where CRP is a major driver of what we're seeing. And I think when we look at everything, it's an inflammatory response when we're talking about the vascular disease. So it might be that if you're able to look at vascular markers and you can see them improving, you might be able to say to the patient, listen, you're getting those benefits that are not weight loss mediated, but there's no big clinical trial that's done that. I think the other place that one thinks about this, and we should, this talk wasn't focused that much on diabetes, but when we think about diabetes, and I say this to people all the time, ask yourself, why were these medications, the GLP-1s, actually developed? They were developed to lower glucose. They were not developed as weight loss drugs. These have become bonuses that we see. And we know that some people will respond with a lowering of glucose without weight loss as well, because they have dramatic effects on the beta cell. So I think that the important thing is to educate your patient about why you're using it. If you've got somebody with diabetes and you're wanting weight loss, well, if we don't get all the weight loss we want, we're getting phenomenal glucose control, and we know what the bad side of that is. So let's take the 7 pounds of weight loss versus 27 pounds of weight loss, because your hemoglobin A1C is now 5.7, right? And then if you're looking for weight loss and that's all you're driving it and you don't get a response, then maybe you're going to get a benefit for cardiovascular disease, but it's a maybe. We don't know.
Okay, thank you. Is there any question online? Okay, here comes the second one. How significant is the risk of NAION, the eye complication, and how should this adverse event be communicated to patients and the management clinically?
So to be absolutely honest, I have not seen a case. I think it occurs, no question, and I think we're becoming more and more aware that it's becoming more frequent. I think, and one of the problems with all these adverse events is they come through these reporting systems to organizations that are basically the drug regulatory organizations. So for every case that you get, you don't get equal number of cases that didn't get it, right? They just don't get reported. So I think it's there. I think it's becoming more visible. I don't think we know yet whether it's totally a class effect or not a class effect. I think that's got to be sorted out. And I think you've just, as a non-ophthalmologist, I think you're just watching your patients and warning them like everything else that there's this potential risk, but it's very, very small. From running diabetes care, we're seeing papers come in on this, but the data is so bad, a lot of it from the databases, that you just don't know what's really happening in terms of its prevalence.
Yeah, thank you. As you know, my wife is an ophthalmologist, so I have discussed this issue with my wife, and she said the same thing like what you said, that this complication is a very rare situation, and more importantly, there is no risk factor identified to predict the occurrence or not of this complication. So what we can do is, if the patient asks about this complication, we discuss with them and share with them about the potential benefit and the minimal risk of this complication, and make shared decision making. Yeah, thank you.
I think what you just said there right at the end is a critical thing. It's a risk-benefit ratio. Whenever we're treating patients, right?
Yeah.
You're going to treat them with a drug, it has a side effect. Is the risk and the benefit aligned? And it's got to be a joint decision. I think we're gone the days where you walked into the doctor, whatever the doctor said, oh, that's the gospel. The doctor knows best. You've got to decide with the patient, and they're willing to tolerate this side effect, but not that side effect. Otherwise, compliance becomes a problem.
Yeah, that's even more true in this AI period. Yeah, patient as AI for everything.
Right, exactly.
Okay, so here comes the next question. For patients found to have fatty liver disease or elevated AST/ALT levels during routine health screening, what further workup and management would you recommend?
So I'm not a hepatologist. Let's start off with that. So I think you've excluded other sort of infectious causes for, liver disease. I think you're going to work them up. I mean, people will start with things like FIB4, and was that fatty liver just found on the basis of an ultrasound? And then they'll do FIB4, and then they're doing elastography looking for fibrosis. I think most patients are not getting biopsies anymore, right? But I think you're basically going to look, and my response would be, if you see what looks like bad liver disease, just like you've got somebody who's got very badly controlled diabetes, you pass that on to the specialist to deal with. And that's what I would argue. I mean, you can do the basic tests, and you can give them some of the drugs, semaglutide, resmetirom, these other drugs that are approved, and see what happens. But if you feel it's getting beyond you, I think you shouldn't hesitate to pass them on.
Yeah. In Taiwan, the health checkup or health examination is very popular here, and the access to this kind of institution is easy, easier in Taiwan than in the U.S. So it's a common situation that our patient with diabetes